Menopause is often discussed as a series of physical symptoms or a psychological reaction to aging, but the clinical reality is more specific. The transition is a distinct neurobiological event that alters the brain's internal environment. As levels of 17-beta estradiol and progesterone fall, the central nervous system loses the steroids that historically maintained its stability, leading to systemic destabilization. Estrogen receptors concentrate in the prefrontal cortex, hippocampus, and amygdala, shielding against oxidative stress. When estrogen drops, this support fades. Serotonin synthesis decreases as tryptophan hydroxylase falls, while dopamine and GABA lose modulation needed for stability. The loss of endogenous buffering leaves neural circuits without their primary regulator. The resulting psychiatric symptoms are the direct, measurable outcome of this neurochemical withdrawal. This chart shows SWAN study data, following over 3,000 women for a decade. It confirms the menopausal transition is a high-risk window for clinical depression. The risk is highest during late perimenopause, where odds of a depressive episode reach 1.71 compared to baseline. These episodes often present with atypical features. Instead of classic low mood, women frequently report extreme irritability, pervasive fatigue, and anhedonia, the loss of the ability to feel pleasure. This period is also characterized by menopause-related cognitive impairment, or MRSI. This phenotype involves objective deficits in word retrieval and memory, linked directly to the high concentration of estrogen receptors in the hippocampus. While these cognitive lapses can be distressing, they typically stabilize once the brain adapts to a low estrogen environment. Distinguishing MRSI from progressive neurodegeneration is essential for accurate clinical management. The domino hypothesis explains this interaction. Progesterone decline disrupts GABAergic circuits, triggering hot flashes and night sweats. This fragmentation of sleep forces the HPA axis into hyperactivity. The resulting cortisol spike further destabilizes the brain's capacity to regulate mood. Stabilizing the thermoregulatory center and restoring sleep quality acts as a primary psychiatric intervention, interrupting the physiological cascade before it triggers severe mood dysregulation. In some cases, the withdrawal of hormonal support precipitates more severe presentations, including first-episode psychosis or the relapse of established psychotic disorders. This is driven by the estrogen-dopamine axis. Estrogen modulates dopamine D2 receptors, providing a natural buffer against overactivity in the mesolimbic pathway. As estrogen declines, this protection is removed. The pathway becomes vulnerable to dopaminergic hypersensitivity, increasing the risk for psychosis. This chart compares psychiatric incidence rates during perimenopause using UK Biobank data. Schizophrenia spectrum disorders show no significant association, maintaining a relative risk of 0.95. However, the incidence of mania more than doubles. The relative risk climbs to 2.12, the strongest psychiatric signal. These findings suggest that perimenopausal psychiatric risk is primarily an affective circuit phenomenon, a disruption of mood regulation, rather than a late-onset form of schizophrenia. Despite these distinct mechanisms, psychiatric prescribing remains sex-petrol. This oversight means the specific hormonal drivers of perimenopausal illness are rarely addressed in standard care. A woman presenting with perimenopausal mania requires a formulation that accounts for this affective circuit vulnerability, rather than a generic schizophrenia spectrum framework. To understand these midlife crises, we have to look past the immediate symptoms and view the patient's history as a single, coherent narrative. This is the reproductive hormonal sensitivity trajectory. It maps a lifelong pattern of neurobiological sensitivity to changes in the hormonal environment. The first signal often appears at menarche, where a sensitive nervous system reacts to the onset of the menstrual cycle with severe premenstrual mood symptoms, or PMDE. This sensitivity often resurfaces during the reproductive years, manifesting as postpartum depression or psychosis following the dramatic hormonal drop after childbirth. For these women, the perimenopausal transition is a predictable convergence point. The severe mood shifts at midlife represent the culmination of this lifelong sensitivity. These are not three separate diagnostic events. They are three distinct expressions of one underlying phenotype, a nervous system that is highly reactive to hormonal flux. The central diagnostic question changes. We are no longer just asking if the patient is depressed. We are asking what her history reveals about her nervous system's long-term sensitivity to hormones. This shift in thinking leads to a specific clinical requirement. Before increasing psychiatric medication in midlife, clinicians must evaluate the underlying hormonal substrate. For many women, menopausal hormone therapy is the primary intervention. By stabilizing levels of estradiol and progesterone, HMT supports the neurotransmitter systems and addresses the physiological drivers of mood instability. NK3R antagonists provide a targeted non-hormonal option, specifically modulating the hypothalamic neurons that drive vasomotor instability and sleep disruption. These pharmacological tools are supported by psychological strategies like CBT-M-Meno and lifestyle factors, specifically the anti-inflammatory and neuroprotective benefits of the Mediterranean diet. Adopting a hormone-informed framework shifts the clinical focus to the underlying biology, providing a foundation for neurological resilience during this high-risk transition.